Yeah, I can see it. Yeah, it's in the presentation mode. Yeah.
Thank you so much.
Right. So how often you run these meetings?
So we just ran last one in August, I guess. And so not very frequent. We have just recently started these and planning to do it one every quarter. We have done, we focused on GI and lung cancer in last session in August, and October we are doing the breast session. I do hope that we are planning another one in end of this year or early next year, like December or Jan. Okay.
So you get a lot of people from India to join, right?
Yes. So actually we have lab in India and another lab is based in UK, Guildford, and another lab is in US. So mainly UK is our hub for international testing. So we have quite a good presence in UK and Europe too. So we do get good number of joinees from there and India, of course.
So I should know your lab. That's Data Cancer Genetics.
Yes, it is.
That's the lab. Okay.
Jamie, I have joined in as well. I'm listening in. I'm just 2 minutes from my home. I tried to make it home just because if I don't, then I have 2 sessions and back to back. I would have till 10 p.m. I would have been in the work in my clinic. So.
Oh, really? Okay. I hope you're being driven. You're not driving.
Oh yeah. in India, it's just that's one thing. One negotiation I did with my husband before I moved back, that I'm not going to be driving here, because it's just the traffic is so difficult. So I just wanted to thank you. Of course, Darshana has already said, but I wanted to thank you for joining for the panel also. I didn't know whether you'll be able to make time, and Massimo has joined as well. So, Massimo, good morning.
Good morning.
Hey, Massimo.
Thank you. So we now have.
Hi, Jim.
Hey.
I remember you in the car. I don't know how many times I've seen you in the car.
You spending maximum time in the commute and. The hours that are there for US and India, it's mostly like this.
Yes.
So we have.
Good morning, Darshana.
So, Darshana, you want to say something, discuss something with Massimo? We can't hear you. You are on mute, Darshana.
Yeah, I just wanted to give you again a brief agenda lineup, brief you on that. So first, I will introduce everyone in first 5 minutes. Then I will hand it over to Dr. Limay for the comprehensive genomic profiling session discussion. Followed by that will be talk from Dr. Abraham and then Dr. Massimo, and last will be case discussion. We just cut down the cases from 4 to 2 because we may have just 25 to 30 minutes for case discussions, and 4 cases will be, I think, too difficult to finish. So, and after 20 to 25 minutes of each session from the keynote speakers, we have decided to have at least 5 to 10 minutes for Q&A sessions for those 2 sessions, for each session actually.
Great.
And Jamie, I just wanted to say this, since we had requested mainly for the first panel followed by a talk, please feel free, post that, because I know that the second half of the presentation we had not discussed with you. So I don't want to impose.
Right. I'll stay for Massimo. I always learn something from Massimo. So
yes.
Come on, Jim.
Hey, I've been learning from you for the last, what, 10, 15 years. So I need to learn something more. So
We are thrilled to have you both, because I was just telling Dr. Hari Bhakti, it's his birthday today. So Jamie, you know him, my director. So I excused him from not joining in today. And I said, but I'm so excited to listen in. And that's Dr. Ved. Dr. Ved is going to be joining us as an expert from India. He's going to be moderating the case discussion section. Dr. Ved heads the Medonk division in Medanta Hospital in New Delhi. And Darshana, I think we are in the last one.
Yes.
So, Sevanti, I've joined, and hello to everyone.
Yes, sir. Yes, sir.
Good evening and good morning, good afternoon to everyone, wherever you are. And happy to be here. Thank you.
Yes, thank you.
Yeah. Great seeing you, Dr. White.
Just an update, Dr. Srinivas Kulkarni is our another faculty, but he's traveling, so he might be, just joining in for a brief few minutes. And Dr. Menon will be joining for the last session. He is not available for the first session, first two sessions.
Yeah. Good evening, Dr. Darshan. I am there actually.
Okay.
I mean,
yes. Okay, so you'll be available. Okay. We are waiting for Dr. Siddharth. He's the another faculty who will be joining, and then we are set. I think we can start. IT team, we can start it.
Do we go to a different session, or are we staying in the same session and doing the presentation here?
So we will be logged in, and the practice session will be changed to the live session.
Okay, good.
Can we start with live session, ma'am?
Yes, please. IT team, you will have to mute yourself.
Yes. It's online, ma'am.
Yes. We'll wait for a few more participants to join, then I'll begin the session. So I think we can begin the session. I'll just start by saying good morning, good afternoon, and good evening to all participants. And I welcome you all to today's webinar on breast cancer. Thank you for taking time out today and being here. I'm Dr. Darshana, the Medical Director at Datar Cancer Genetics. And this October is a breast cancer awareness month. And around that theme, we are today going to focus on raising awareness around the breast cancer. We have lined up expert faculties from USA, UK, India, who will give us insights into the breast cancer, new strategies to tackle breast cancer, and how the therapy landscape is evolving, and how the smart genomics can really help us to change the outcomes. We will also have some case studies lined up at the end of the session. We have essentially 4 sessions scheduled for today, and we have also, after each session, we have a brief Q&A session. I'll just start sharing my screen. Yes. So we will have question and answer session at the end of each session, and we have enabled ask a question section. So if you have any questions, please pop them in there, and our expert faculties will address those. Before we move on to the first session with Dr. Limay, I'll just like to introduce today's faculties. Even though they are so well renowned in their own field that they really do not need any formal introduction, but as a formality, I'll do it. Dr. Cristofanilli is the Director of Breast Medical Oncology and Associate Director of Precision Oncology at the Mayer Cancer Center at Weill Cornell Medicine and Newark Presbyterian Hospital. Dr. Cristofanilli is an internationally recognized expert, and his work is in the metastatic breast cancer, early breast cancer, but with special emphasis on inflammatory breast cancer, which is a difficult to treat malignancy. His research in novel drug development, circulating tumor cells, and liquid biopsies has led to improvement in treatment of breast cancer. I welcome Dr. Cristofanilli to the session. We also have with us today Dr. Jamie Abraham. He's the chairman of Department of Hematology and Medical Oncology at Cleveland Clinic. He served as the director of Cleveland Clinic Breast Oncology Program. With more than 2 decades of experience in treating complicated breast cancer diagnosis and leading novel clinical trial, he is a great asset to have today with us as an expert faculty. Dr. Abraham is a member of NCCN Breast Cancer Committee, which sets the treatment guidelines for breast cancer. With this, I also welcome and thank Dr. Jamie Abraham for joining us today. Dr. Tim Crook also will be joining us. He's a consultant at Cromwell Hospital, London. He specializes in management of breast cancer and advanced breast cancer, especially melanomas. He continues to actively participate in basic translational research with particular interest in precision oncology. We also have Dr. Ashok Vaid. He is a chairman of Medical Oncology, Hematology, and Stem Cell Transplant at Medanta Cancer Institute, New Delhi, India. He has 30 years of clinical expertise with special interest in cancer genomics, immunotherapy guidance, precision oncotherapeutics, in addition to the stem cell transplant, which he started one of the first largest stem cell transplant programs in the private sector in North India. And we have Dr. Semanti Lime, the Director of Medical and Precision Oncology and Director of Clinical and Translational Oncology Research at Sir H.N. Reliance Foundation Hospital, Mumbai, India. She is co-hosting this session with me. She has established the first medical oncologist-led precision oncology clinic in India. Dr. Lime has immense experience from working in various US universities, including Columbia University of Medical Center, Dana-Farber Cancer Institute, as well as Harvard Medical School in Boston. I welcome Dr. Lime. Another faculty that we have today is Dr. Siddharth Sahni. He's the Director of Breast Oncology Surgery at Fortis Hospital, New Delhi, India. He will be bringing his viewpoints through surgical lens for today's session, focusing on mainly the treatment with a lens of medical oncology. He's qualified in surgery from Royal College of Surgeons, obtained his certification with specialist training in breast surgery from Veronese European Institute of Oncology in Milan with Professor Umberto. Dr. Sahani is certified tutor at Royal College of Surgeons, Edinburgh. I welcome Dr. Sahani to today's session. Dr. Mohan Menon will be joining us a little late today for today's session, but still I'll do the introduction. He's a medical oncologist at H.N. Reliance Foundation Hospital, Mumbai, India. He has worked as a medical oncologist in Greater Hartford area of Connecticut for almost 2 decades and is currently serving as a visiting consultant there. He's a member of several professional societies, including ASCO and Connecticut Oncology Association. Last but not the least, we also have with us today Dr. Srinivas Kulkarni, who is a medical oncologist working at Sahyadri Super Specialty Hospital in Pune, India. He has completed his training in medical oncology from Manipal Hospitals, Bengaluru, India. His area of special interest include implementation of newer modalities such as MAPS, oral TKI, essentially with focus on precision oncology, at the same time improving the quality of life in cancer patients, sparing them toxicities of these chemotherapeutic agents. With this, I will just hand over the session to Dr. Lime, and I will request her to begin the webinar, kickstart the webinar with the breast cancer precision oncology discussion. Over to you, Dr. Lime.
Thank you, Darshana. That was a great introduction for everyone. And truly, it's a pleasure today to witness all these stalwarts that we have in the session. Especially looking forward to the 2 talks that are coming through. I thought when we had so many of the leaders brought in together in one session, how better to start the session with a warm-up. The warm-up is here in a focus into breast precision oncology. And the reason to do it this way, to start the session with a panel discussion, is mainly to understand the patterns of practices globally. We are waiting for Dr. Tim Crook to also join, but we are here today with faculties from the US and experts from India. And Dr. Crook, with Dr. Crook joining in, we will have the UK presence as well. So a global representation in today's webinar and a very quick rundown on patterns of practices in precision breast oncology to try and quiz everyone and see what are the routine tests we do, how do we approach our breast cancer patients, and how do we then finalize the strategies for treatment. So again, a big thank you to all the experts for joining in. I am just going to quickly share my screen. Okay, so here we are for chat. And the earlier Twitter logo used to be a better logo. And now we are stuck with this ominous looking X, but that's how it is. And that's me starting the first question for the session. So when we talk about precision in advanced breast cancer, and I begin with an anecdote there. It's just a few years back that I was presenting a talk on precision breast cancer at one of the big events in India. When I went in, I had around, I would say 40 slides with all the new stuff that was happening, that was all pathway directed. And I entered this room where those who know Dr. Sudeep Gupta, who heads the medical oncology, breast oncology division at Tata Memorial Hospital, he was chairing the session. And one look at him, and I immediately made some changes to my slides saying, this is hypothesis generating, and this would be coming because he's a traditionalist and he follows ASCO guidelines, and only ER, PR, and HER2 had any bearing and nothing else would do. And that is then, and here we are now. I wouldn't say we have changed by leaps and bounds, but there are some patterns of practices that have changed, and precision has arrived in breast cancer. And I thought, what better than to discuss that with the esteemed colleagues here. So to just begin with very, very casually, what biomarkers do we look for in advanced breast cancer if a patient presents? I have a curtain raiser because I just in my clinic today saw a patient that Dr. Jamie Ibrahim had referred to me. And I already had the, I think there was a cheat sheet in his email. So I knew what he was expecting. So the first question to you, Jamie, what do you do when you have a patient with advanced breast cancer in your clinic in Cleveland?
Thank you, Savanthi. I really appreciate your kind introduction and invitation for this session. Again, thank you for seeing that patient on a short notice in less than 24 hours. That's pretty impressive. Thank you.
Thank you.
They were thinking they won't be able to see you for the next 4 weeks.
I know, we got them in very, very quickly. Yes.
Okay. So, as you're kind of saying, the breast cancer landscape is changing as we speak. So when you say advanced breast cancer, then I'm going to just divide that into, let's just say triple negative and ER positive, and then HER2 positive. So let's just say, like you, I just saw somebody with a triple negative de novo metastatic breast cancer. She's 54 years old. She just presented with extensive bony lesions, large liver lesions, and didn't have a primary breast lesion and seen or palpable in any of the testing. So for someone like her, I will do a germline testing, looking for BRCA, because I can target that. And then, of course, I'll do a PD-L1 testing so that I can use Pembro. So that's about 40% of the patient. And as you know, BRCA is probably 5 to 10%. And then I'll order an NGS panel at that point to see if we can use any other potential targets in the future. So triple negative, I'll order that right away. In ER positive, usually I wait for, initially I'd start with the first ER positive, start with the CDK4/6 inhibitor. And then when they progress on an endocrine agent, then I'll do the ESR one for sure, and then do an NGS at that point. Again, depending upon the family history, I'll order for the germline testing. So I'll pause.
Thank you. Thank you. So that was great to know. It's slightly different from how I do it, but it was great to know your style of practice. And just to check in on one of the Indian leader mindsets, Dr. Vaid, how would you approach a patient? Would it be a similar style, a different style? How do you?
It was almost similar. The basic 3 parameters are all listed out here. PD-L1, we have access and we are using the IO on a regular basis, and of course the germline testing. And I think these are at least the basic minimum one would do. But your question about do you do NGS? We have not been doing NGS as often, but we started doing it. I think it's a more of a learning and an evolutionary sort of a standpoint, and we have started doing that. Probably not at the time of diagnosis. We were definitely doing more at the time of first progression. But at the time of diagnosis, as I said, at least about those 5 or 6 parameters one would do.
Thank you. So yes, so Dr. Vaid reflects that they've now started doing NGS for a lot of their patients, and it is now becoming a standard of care. Massimo, coming to you, what germline would you send in your patients? Do you send comprehensive germline? Do you send focused germline testing? Or what is the routine that is available at Cornell?
Yeah, I think we have Ambry different panels. You go 36 genes, and you have pretty much a comprehensive that are of interest for genetic risk and potential therapeutic targets. So this is pretty standard. We never do very focused 9 genes with BRCA1 and 2, PALB2, and CHEK2 or a few others. If you were to do it, why don't you do a larger panel so you can see the risk for additional malignancies? And a lot depends in general. In the past, at least, it used to depend on the family history. The type of patient that you see. As you know, we have a large population of Jewish, Orthodox Jewish in our clinics. So I would say pretty much the majority of patients requires a larger panel for germline testing.
So larger panel for germline testing. And for a hormone positive patient, do you do NGS for that patient when they present with metastatic disease, or do you wait?
Yeah, that's an interesting topic of discussion, because at least our patients have all been exposed to endocrine therapy in the adjuvant setting. So I would say that there is some sort of either primary or secondary clinical resistance, and you want to know what type of molecular resistance you have, right? So I favor to do NGS, and of course liquid biopsy, why not? Upfront at the first line therapy, that, as I say, likely is a progression from prior adjuvant therapy. In the future, we're going to have progression from CDK4/6 adjuvant, so it's going to become a more molecular complex disease. And I think this is an area where we just need to learn how to use the information more than anything. And in many cases, I mean, there is no strong guidelines to do it first line, but there's more and more routine use, at least in the US, especially when the insurance covers the cost.
Right. So I think we are moving more and more towards understanding the genomic landscape of the disease better, and doing the NGS either upfront or on first progression is what I'm hearing. In HER2 positive breast cancer, does anyone do an NGS upfront, knowing fully that there are, what do I say, multiple lines of therapies already aligned? Any takers for that?
Oh, sir. Hello.
Yes.
Yeah, Dr. Srinivas here.
Yes, please.
Yeah. So as you rightly said that we have multiple lines of anti-HER2 therapies available, we usually don't end up in doing NGS upfront in HER2 positive diseases. And yes, I do agree that in other subset that we used to do NGS at first progression or subsequent progression, we would like to see, there are various mechanisms of HER2 resistance. So not at presentation, but definitely at progression, would like to do NGS in HER2 diseases.
Great thought. I think most of us are doing that, but some of us are also doing upfront. So interested in knowing if anyone would think otherwise. Would anyone do any other testing first in terms of doing a comprehensive genomic panel for a HER2 positive patient upfront, and secondly, liquid biopsy tracking? So I think that leaves Mohan and Dr. Sahni. Dr. Sahni, I'm going to come for the early breast cancer, but please feel free to chip in. And Dr. Mohan Menon has joined in as well. Darshana, I don't think Dr. Tim Crook has joined in yet, has he?
No, not yet.
Yeah. Okay.
So as far as liquid biopsy is concerned, I haven't been using them routinely. And NGS depends upon the type of breast cancer. TNB, as Jamie had mentioned earlier, is a situation where I think you're looking for a target to hit besides giving chemotherapy. And in that situation, perhaps getting an NGS earlier makes sense. Where you have a target, it's probably sensible to first treat that target. And it's only when you run out of bullets that you look at other ways to treat it.
Great, thanks. Great. So now that we have heard from everyone with different approaches for hormone positive, triple negative, and HER2 positive, what I'm hearing is there are differences. There are no specific styles. I think most of us are doing it upon progression. Some of us are doing it at the first presentation of the patient. If I were to really come together, put together what we said, it is important to have an idea of the lay of the land, and especially if you have a progression on frontline therapy, most certainly. I will present a counter thought and then come back with final thoughts for this slide. So the counter thought is, many times when you have a second line therapy requirement, you may be running short of time, you may be running short of that ideal lesion to biopsy, and there may be other logistic challenges, and you may not know what happened. And in the first presentation, when the patient presents, most of us have a biopsy. And does that make a case? And I say that only because I follow the Massimo pattern. I do the frontline testing. So I'm curious to know, would anybody think that way, that we need to at least define the landscape right at the start, and whether, just fearing whether you would get another chance or not?
I would, I mean, I'm a simple surgeon, so I don't have the challenges that all of you do in terms of recurrence, etc. But it's the point I was trying to make is that I think we don't give antibiotics now without a culture of sensitivity. And I think the way it's going in the future, I think it's best if you know, because you at least will potentially find out in which patient you would have failed had you stuck to, what is supposed to be gold standard therapy. Because there are patients, and you and I have been discussing this young lady in Delhi who's an ER/PR positive patient and has had multiple lines of treatment and continues to recur and will only do well if she gets an NGS and a liquid biopsy and an Exacta. So had this patient been worked up right at the beginning, of course, the problem here is the cost factor comes in, and insurance companies need some sort of guidance into supporting this as an integral part of the planning of the treatment of the patient. My opinion.
Great. I think I really echo your thoughts here, wherein understanding the biology for me is most critical, and if given a chance, one does not want to miss that. And so I see that the horizon is changing. There is a lot of emphasis coming on biomarkers, but I also get the counter thoughts where upfront there is a standard of care already defined, and in breast cancer much more prominently than many other malignancies. I will not stick on this slide because we are already running quite late. So I will jump to early breast cancer and ask some of the very, very pertinent questions to our faculty here. So for a patient presenting with early breast cancer, just taking the thought from Dr. Siddharth Sahni and bringing it in here, we now have started treating our patients with breast cancer differently, right? It has become a standard of care difference where a triple negative breast cancer patient does not get upfront surgery, is given neoadjuvant therapy, whether it be just chemotherapy or chemotherapy and immunotherapy. Everybody is thinking and aligned with these ideas. But we don't test beyond that. We don't test beyond ER/PR and HER2/neu. Even the PD-L1 as a biomarker has not shown correlation for immunotherapy application, right? For Pembro, irrespective of the PD-L1 status, based on the Keynote 522 data, we have to give immunotherapy. So just very salient question to everyone, and then we move to Dr. Abraham's talk. So starting from Jamie, what do we think about the biomarkers? Do we have enough in early breast cancer? I mean, why do we not do any in-depth analysis yet for our early breast cancer patients and work with only majorly 3 biomarkers?
Yeah, sure. Again, thank you, Suvanti. So to recap the previous conversation,
yes,
I like what Dr. Sahni said. We don't treat a bacterial infection without the sensitivity. So that's really a good analogy. So as you're saying, the tumor continues to evolve. So repeated testing when the tumor progresses to understand the current status of whatever the mechanism of resistance, and I think that's the way I approach. And then the second thing, freely available liquid testing, without subjecting the patient for a repeated biopsy. The liquid biopsy is really allowing us to do that in a dynamic fashion. So coming back to this one, You're right. In early breast cancer, especially in ER positive setting, node negative, 1 to 3 nodes, especially in postmenopausal, that's and as all of you know, routinely used. I don't treat any patient without some kind of genomic testing. At Cleveland Clinic, we use Oncotype. Of course, MammaPrint data is really strong. That's routinely done. And then, and I don't do any other breast cancer index and other things to decide the duration of treatment. Only in selected patients, I may do a BCI index to see if I should extend the treatment beyond 5 years. Usually I'm using the clinical and pathological features for duration of endocrine treatment. And then, of course, and as Massimo is saying, in patients who meet the criteria, of course, I'll recommend genetic counseling and genetic testing for all the patients.
Great, thank you.
I just want to say that the reason I say that is that if we are talking about early breast cancer, then these are precious patients, because if you look at the data, you should not be having any recurrences really in early breast cancer. And if you can get more information, HER2 positive and triple negative, yes. My role as a surgeon is now gone a step back, and it's only after neoadjuvant therapy has been given. It's great because I've started doing less and less mastectomies. Patients are happier. Makes me look like a better surgeon as well. But I think if we have more information, I think especially this subset of patients, which is, it's like, it's a very precious subset. You should not be having a recurrence in early breast cancer for a patient who's bothered to go get herself screened, has found usually a screen detected anomaly or detected herself. I mean, this patient you should be guaranteeing her disease-free survival for at least 30 years without any form of recurrence. And that's the platform I'm coming from. Because it's so sad to see somebody with a 2-centimeter cancer have a recurrence within the first 3 to 4 years.
Thank you. I think very, very, so it's an emotionally charged discussion. I think it is all very important to be laid out. Hopefully, we will have more biomarkers to guide our treatment, as we already do for many of our patients. Massimo, just thought about the liquid biopsy. Can't leave the session without posing this question to you. Do you routinely use liquid biopsy tracking for MRD monitoring? And we're going to hear more in your session, of course. But do you utilize it in MRD, and do you utilize it for decision making? And last question here, in that line, if you were to find an MRD positive patient who has already gone through treatment, what do we do in today's time?
So I think to answer the first part of your questions, I don't use MRD in every patient or in every subset or subtype of disease. We're going to discuss more in my presentations. So assuming that we have done this MRD is positive, of course, you need to have a closer monitoring. You need to restage. You need to make sure, depends on the timing. If the patient has just finished local therapy, they would need to do probably, the Xeloda as adjuvant treatment in patients who have residual disease and pembro, and see how this will affect the MRD if there is no evidence of recurrence. Or if much later, it's probably think about an intervention. Right now, the intervention for MRD are mostly in clinical trials, but in some instances, for example, ER positive, you can imagine that you're going to start a CDK4/6 early if they are on single agent endocrine therapy. So there are considerations, certainly. And we're going to talk about the situation where in the past, we used to just intervene with patient symptoms, not even imaging. Now we have either we detect early metastatic disease, so maybe more treatable than in the past, or detect a molecular recurrence and not a clinical recurrence. And this is obviously the holy grail, what we're going to do about really treating before we can see an anatomical recurrence.
Thank you. Thank you. So we have to close this session and go to Dr. Abraham's talk. Before we do that, I have three of our eminent medical oncologists, and I will ask, are any one of us doing MRD tracking for our patients? And is there a patient that you would think of to do the MRD tracking, or just from the Indian perspective? Dr. Vaid, are we doing?
We don't do it. We are not doing it. You know, Sevanti, there are two reasons primarily. The major reason is the cost implication. Insurance doesn't cover. And as it is, the most of the targeted therapies and the immune checkpoint inhibitors are a huge financial burden. And though the counterpoint could be that the therapy could be better tailored and withdrawn or done at an appropriate level, and not to continue the futile therapies. But then sadly, that's the way things are at the current point in time.
Right. Well said. Mohan, Dr. Srinivas, anything?
From my perspective, I think it's a little too early to do MRD testing and so on and so forth at this point. I don't know what it means if the cells are there at this point. Perhaps it may mean that the disease may come back. We do have data from colorectal and certain other areas where it perhaps means something from an adjuvant perspective. But I would not initiate therapy till we have disease that is visible, rather than what you see on cells. So at this point, no, I have not started doing that.
Thank you. And if Dr. Srinivas is logged in?
Yeah, I'm there, ma'am. So we know that even globally, the data of MRD tracking in such malignancies is not that robust. We have just started, and it's too early to comment on. And at least Dr. Vaid sir has rightly pointed tremendous, healthcare burden on us. So it will not help us in deciding the treatment of choice. But yes, the tumors which are more immunogenic, especially triple negative subset of the breast cancers, and probably these can be right now in Indian context. I would say it's a gray area.
Thank you. So I got that bit. So we look with this, Massimo. We are all ears to your session, and we're going to learn how to utilize the liquid biopsies, and also Darshana, back to you to develop more MRD, local MRD testing, so that it can be cost effective, and we can do this as a routine after learning from what Massimo has to say. But handing the baton over back to you, Darshana, for Dr. Jamie Abraham's talk, and really looking forward to that. And again, thank you for doing this for us. Thank you.
Thank you, Dr. Limai, and thank you all the faculties. It was a very interesting session, and I'm hopeful that the participants will be deriving a meaningful takeaway from further clinical practice here. There are certain unanswered questions. We'll be coming back to those questions very soon. But I will like to invite Dr. Jamie Abraham for his presentation on ADCs right now. Thank you. Over to you, Dr. Abraham.
Can you see my slides now?
Yes.
Okay, in presentation mode, right? Yeah. Okay, good, very good. Again, thank you for the invitation. So I'm going to talk about antibody drug conjugates in metastatic breast cancer. So I have no financial conflict other than research support from the companies listed here. So I'll focus on two drugs primarily. I'll focus on TDXT and then sacituzumab govitecan, and I'll review some of the data with the Dato-DXd. So as all of us know, ADCs are really revolutionizing the breast cancer treatment at this point. So it has three components. It has an antibody, which is targeting the antigen, which is, and then of course a linker, and then a cytotoxic agent. So the antibody is targeting the antigen, which can be tumor specific, minimal expression in the normal tissue, and the antibody can be internalized. It's not, it's prevalent only in cancers. Then a linker molecule, which can be cleaved within the tumor, or it can be in the peritumoral area. And then the mechanism of action of the cytotoxic agent could be either a microtubule disruption or DNA damage or transcriptional inhibition. And a number of the agents which are listed here, DM1, SN38, which are used in clinic at this point, which we are going to talk in a second. So TDXT, trastuzumab deruxtecan, is probably the most active ADC. I'm going to just say ADC, not just HER2 targeted or overall ADC in clinical use at this point. And I'm sure all of you are really familiar with this compound. It has three parts: a humanized anti-HER2 IgG, one monoclonal antibody, which has the same amino acid sequence as trastuzumab, that's linked to a topoisomerase 1 inhibitor payload, exatecan derivative DXT. And it has some really unique features, some 7 key attributes. It's a design molecule. The payload is really an active component. It's a topoisomerase 1 inhibitor. It has high potency. The drug to antibody ratio is 8. So there's a heavy delivery of cytotoxic agents into the tumor. This data in HER2 positive breast cancer. So if you look at all the Destiny trials from Destiny 01 to 2 and 3, 01 in heavily pretreated patients, the response rate with TDXT was up to 70%. And then when you keep going to Destiny 02 and then Destiny 03, Destiny 03 compared TDXT versus TDM1 in first-line HER2 positive metastatic breast cancer. The dose is the standard dose, 5.4 milligram. The primary endpoint is progression-free survival. Again, this data is well known to all of you, which showed a substantial improvement in progression-free survival. And you can see the p-value, which is really unseen until the TDXT emerged to the market or to the scene. So based upon this data, TDXT, we included that in the NCCN guidelines as the first agent. Once the patient progressed, the THP regimen, pertuzumab, trastuzumab, docetaxel regimen. Then initially in the second line setting, TDM1 was listed. Now TDXT is moved up to as the first agent. So moving on, I'm going to actually mainly focus on hormone receptor positive and triple negative breast cancer setting, because I think HER2 positive setting is well established and all of you are really familiar with that data. So let's look at hormone receptor positive setting. So let's look at this patient. She's 57 years old, history of hormone receptor positive, HER2 negative. So I'm going to here HER2 negative. I know I need to define, and I'm saying it's immunohistochemistry IHC 0. She progressed on multiple lines of endocrine treatment, plus CDK4/6 inhibitors. And of course, she was on one line of cytotoxic agent. So many of us, those who've been doing breast cancer for many years, the story which is really making all the difference is the quality of life. And any patient, even with an extensive disease, doesn't matter lung or liver lesions, they can be managed for years without a cytotoxic agent, and they will be able to maintain a quality of life. So we have a number of CDK4/6 agents, estrogen receptor downregulator, now ESR1 blockers. So this patient progressed on all these agents. So in this setting, so HR positive, HER2 negative, with or without visceral crisis, the patient, let's just say, endocrine refractory. So the choices are, let's just say, if the patient's tumor is IHC0, means not a candidate for a TDXT, sacituzumab govitecan is the drug of choice. At least that's the way we treat. So what's the data? So that sacituzumab govitecan is a first-in-class TROP2-directed antibody-drug conjugate. And as all of you know, TROP2 is expressed in all subtypes of breast cancer, and it's linked to poor prognosis. Sacituzumab govitecan is distinct from other ADCs, highly specific. The antibody is highly specific for TROP2. The drug-to-antibody ratio is about 7:1. And then you can see that SN38, that's the parent compound, is irinotecan. It's a highly active cytotoxic agent. So this is the phase 3 trial, which looked at TROPiCS-2, the phase 3 trial, which looked at sacituzumab govitecan in hormone receptor positive, HER2 negative advanced breast cancer. Let's look at the eligibility criteria. Again, metastatic breast cancer, more than one endocrine treatment, taxane, and CDK4/6 in any setting. And this is the randomization, 1-to-1 randomization. And the primary endpoint is progression-free survival. And the dose is 10 milligram, day 1 and 8, and then repeating every 21 days. So this is the patient characteristics in a fairly large study, about 650 patients or so. And the disease burden of these patients, you can see almost 95% of the patients had visceral mets, 84% of the patients had liver mets. So that's in both arms. So heavy disease burden. And if you look at the number of regimens, these are heavily pre-treated patients. The median number of regimens is about 3 in both arms, and up to 8 cycles of agents of cytotoxic agents received prior to enrolling in this trial. So this is the primary endpoint. At 6 months, 9 months, and 12 months, there's an improvement in progression-free survival. And then you can see the numerical difference is not that impressive. It's about 1.5 months or so, but you can see in 12 months, 21% of the patients on SASI has progression-free survival, and 7.1% in treatment of physician's choice. So basically, it's saying in heavily pretreated patients, once they become refractory to CDK4/6 or endocrine agents, the PFS, and again, this is the treatment of physician's choice, PFS is overall poor. And they saw the benefit in all subset of patients, including patients with visceral mets or in older patients. This is looking at HER2 low, IHC0, and intent to treat population. And all these patients, and a subset of patients, there's an improvement in progression-free survival. This is overall survival. There's about 21% reduction in the risk of death by patients receiving SASI, and then about 3.2 months difference in overall survival. So this is published a few weeks back, or a few months back in Lancet Oncology, with the final analysis of the overall survival. As you can see, there is a difference in overall survival, and all subset of patients showed an improvement in overall survival. It doesn't matter the race and how long they had the endocrine treatment, the performance status, and number of agents prior to enrolling on the study. The side effects, again, SASI, because of the powerful topoisomerase inhibitor, it has side effects, mainly GI. Diarrhea is an important side effect. You need to continue to pay attention. Febrile neutropenia, neutropenic colitis. So as I said, if the patient's IHC is 0, ER positive, this is included as a category 1 in the NCCN guidelines. So let's move on to HER2 low. Let's just say her tumor is, of course, ER positive, HER2 negative, but the IHC was 2+. And of course, she progressed on multiple lines of endocrine treatment. This is Destiny-04, and I'm sure all of you are really familiar with this. This really changed how we treat estrogen receptor positive patients once they progress endocrine agents. But 55% of the patients have HER2 low status. And then let's look at the inclusion criteria. Unresectable or metastatic, 1 to 2 prior lines of chemo in the metastatic setting. And this is 2 to 1 randomization, 5.4 milligram per kilogram every 3 weeks. And this is the usual treatment of physician's choice we do. And the primary endpoint is progression-free survival. If you look at the patient characteristics, it's hormone receptor positive in all patients because they had hormone receptor negative in this trial too. So this is Destiny-04 is really an ER positive trial. A majority of the patients had some kind of hormone receptor positive disease. And then most of the patients had, almost 60% had HER2 status IHC 1+, only 42% had 2+. And a number of patients still had bulky disease, and liver mets about 71%. And then a median number of lines of chemotherapy is about 1 before entering on this study. This is really impressive data. Primary endpoint difference is about 5 months with a hazard ratio of 0.5 in HR positive and all patient cohorts. And overall survival, similar, a difference of about 6 months, TDXT versus treatment of physician's choice. And then median overall survival in TDXT patients is 2 years or so. Safety profile, fairly well tolerated drug, but and I keep telling this to my trainees, my fellows, pneumonitis is the most common side effects which we need to continue to pay attention. In general, about 12% of the patients develop pneumonitis, and about 9% will say grade 1 or grade 2. 9% grade 1 or grade 2, and about 3% can be significant. So it's really important to identify the pneumonitis early on. So first diagnosis, second intervention, interrupt the treatment and start the patient on steroids. And you can see that and there was grade 5 events, and we lost some patients on this trial due to pneumonitis. So it's extremely important to pay attention to this. Because of this, we are actually doing a study, of course, you're familiar, Destiny-05, which is moving this drug to post-neoadjuvant setting. That's TDXT versus TDM1 in patients who have residual disease after neoadjuvant treatment. And when we move this drug to the curative setting, it's extremely important to pay attention to ILD because we don't want to lose any patient from a drug toxicity. Again, diagnosing early is really, really important and starting them on steroid. All right, so I'm not supposed to compare two agents, but both agents are active in HR positive patients. If the patient has IHC 1+ or 2+, I'll start the patient on trastuzumab deruxtecan. IHC 0, the patient, I'll treat the patient on sacituzumab govitecan. So moving on to triple negative. So let's just say the patient is triple negative with IHC 2+ and FISH negative, and the PD-L1 score is, let's just say CPS score is more than 10. I treat the patient on pembro containing regimen, and if the patient progress, and then these are the options. Sacituzumab govitecan. If the patient has 1+ or 2+, then we can do TDXT. I know someone posted a question in the chat. I really always, I'm sure all of you said the same thing, really pay attention to BRCA mutation. It's extremely important for us to pick up this because we can offer them treatment. I have a number of patients going on PARP inhibition for years without recurrence. The longest is I have a patient with brain mets and extensive liver lesions and lung, almost 10 years disease-free survival on PARP inhibitor. All right, okay. So our track record in triple negative is not that good. If you look at that median progression-free survival with any of these agents are pretty dismal. And overall survival, again, it's really poor. The only agent which probably really has shown an impressive progression-free survival and overall survival is first-line setting when we treat the patients who are PD-L1 positive, when we treat them with pembrolizumab. 24 months of overall survival, progression-free survival almost 14 months. But otherwise, our track record in this setting is really poor. So this is, we already discussed, DESTINY-04. If the patient is IHC 1+ or 2+, that's the drug of choice. And you saw this data in a different format. This is for triple negative, hormone receptor negative patients, and they still benefited by TDXT if they have 1+ or 2+. So moving on to sacituzumab, this is ASCENT trial. It's a phase 3 trial in patients who had more than 2 prior chemos, a triple negative setting, 1-to-1 randomization, same dose, progression-free survival is the primary endpoint. There was an improvement in progression-free survival in this setting. This is patients without brain mets, and also an improvement in overall survival. In triple negative metastatic breast cancer, again, we have 2 choices, sacituzumab govitecan and trastuzumab deruxtecan, 2 agents. So both HR positive and triple negative, we have 2 options at this point. So SASI is moving up to first line. This is in patients with PD-L1 positive, combining that with pembro. This trial is going on versus treatment of physician choice. And then in patients with PD-L1 negative, again, SASI is moving up, ADCs versus treatment of physician's choice. This is deruxtecan. This is a phase 1 trial. In this trial, triple negative and HR positive breast cancer were involved. Of course, it's phase 1. Safety and tolerability were our primary objectives. The side effects are mainly nausea and stomatitis. They did not see any ILD with this drug, and it has activity in triple negative, even in patients who are received a topo-1 inhibitor. This, I think, it's going to be presented in this weekend at ESMO. This is the phase 3 trial of data in HER2-low positive, HR positive HER2-low patients who are heavily pretreated. Really impressive response rates in this subset of patients. This is combining data with immunotherapy. There are a number of trials going on in this setting, and it's showing in early, it's showing activity in PD-L1 positive and PD-L1 low tumors. So in conclusion, we have 2 active agents, which is FDA approved, guidelines included in HER2 positive, triple negative, and then HR positive, HER2 low, and HR positive breast cancer from trastuzumab and sacituzumab govitecan. And we stay tuned for more data from ESMO on data, and I'm sure it looks like the results are promising. Thank you again. Happy to take any questions. And as Dr. Limaya said, I still like to use Twitter, not the X one, right? Yeah.
X makes it sound so ominous, and the color that it chose, imagine.
Yeah.
Thank you. That was a phenomenal talk and so clear. And I learned. And one of the things to acknowledge here from all the clinicians practicing in India, that at this time, we don't have direct access to any one of these 3 molecules. We can import and give. And thankfully, trastuzumab deruxtecan is launching very shortly. But that's how it is. We have to import at this time. So it's a heavy choice for us, and all the more reason for us to really understand the treatment strategies and implications. I think most of us have utilized these drugs. We have now been experiencing these drugs, both some of us in clinical trial format and some of us mainly clinical, but still, you don't get a free hand till you have it available in the country. And even though most of our cancer care is happening still out of pocket, if it is available in the country, it becomes much more easier for us to give. So with that, I have a quick question, and then to Darshana to ask the other faculties. So in ENHERTU, we understand that the ILD is dose dependent. If I look at the lung study, and because I am a medical oncologist who does all solid tumors, the rates of ILD were much higher than we see with breast studies. And the dosage the breast study was actually where we saw the 5.4 milligram dosing, and the lung study had utilized a higher dosing. Do you experience it that way in your clinical practice? If you were to lower the dosage, do you see even lesser rates? And my second question would be regarding the brain metastasis. What is your thought regarding the blood-brain barrier coverage of ENHERTU for brain metastasis?
Good question, Swanti. So at this point, because I'm treating only one diagnosis, we are using the same dose, 5.4. And then, as you said, it can be seen at any dose level, and it can be seen anytime. Some people say, oh, is it early on? Is it late? It can even see after, let's just say, 6 months or 9 months or 10 months on this treatment. So we need to continue to be vigilant. And then in all the studies which we looked at, if I can say the trouble, if I can say fatality, the patients we lost were patients who were misdiagnosed. Some of the patients had radiation pneumonitis, and they thought it was radiation related. And of course, this drug was developed at the time of COVID, so there was a lot of COVID and ILD at that time. So making proper diagnosis and starting steroid. So I'm almost repeating myself, but I think it's really important for people to know that make a diagnosis, interrupt the treatment, start steroid. So.
Thank you.
Yeah, and then second question. It has I'm sure you might have seen a data recently. I think again from our source of information from social media. There is it's a paper. It just came out in Lancet about its substantial activity in brain, and it's been consistently shown in the past in all the studies. And when they looked at the subsets of O3 and O4. It's really active. And in our clinical practice, I'm sure Massimo can say the same thing. I have patients with brain mets doing really well on ENHERTU.
Excellent. Thank you. Darshana, back to you if others have questions.
Yes. Any questions from other faculties? I just have one question of my own. I'm not a clinician, but still, if you experience ILD with ENHERTU, and as Dr. Lima and you have discussed that dose reduction helps. So once the active ILD has settled, is it feasible to reintroduce it at lower dosage?
Yeah, good question. Good question. So let's just say several things. One, if it's a grade 1 or grade 2, and usually I interrupt the treatment, start the patient on steroid, and then continue to monitor. And if the ILD completely resolves, the patient has no evidence of ILD, then I can consider restarting. So there is no recommendation saying we need to dose reduce. That's not in the recommendation at this point. But if it's grade 3, grade 4, of course, permanently discontinue, and we're not going to expose the patient to that. And I'll just say an anecdote, and then I can. So I had a patient who was on Destiny 05, and again, that's post-neoadjuvant setting. The patient had radiation after the neoadjuvant treatment, surgery. She had radiation treatment. Then she enrolled on the trial. She had some radiation pneumonitis. So you're looking at the X-ray and the CT scan. In the trial, we were doing CTs every 6 weeks. So as you know, that if you do the CTs, it's going to pick up radiation pneumonitis. So patient had lesions in the lung. And then meanwhile, she developed COVID. So now we are in trouble. She had COVID and she has this changes in the CT scan, and she's on TDXT. But after careful review and after reviewing with the study team, we decided it could be related to the radiation, and then we were able to continue the patient and finish the treatment for 12 months.
Wow, great case and analogy.
Great, thank you. And I have a couple of questions from the attendees, but they are mainly pertaining to desire of having Dr. Abraham's presentation. So that is not feasible. But anyway, a great presentation, Dr. Abraham. And I'm glad that Dr. Crook has also joined in. And I will request Dr. Massimo to proceed with his presentation. Thank you, Dr. Abraham, once again.
Thank you for the kind invitation. I hope you see my screen. And of course, it's a great pleasure to be part of this team, this webinar, and presenting one of the topics that apparently seem to have generated a lot of interest. And that is not only an overview of the liquid biopsy, but most important, how we use MRD in breast cancer management. So I want to make, first of all, an introductory slide of what we know about liquid biopsy now. There's been several years of recent development, but everything started pretty much with the first publication of the metastatic setting of CTC prognostic value back in 2004. Even the field of CTC are evolved. We know that now we can do molecular analysis. We can look at expression, and there is heterogeneity in the expression, particularly in the HER2 and ER. And of course, we can look at some methylation of ER as well. So the CTC field has evolved, and the CTC single cell evolution and detection of CTC cluster and extravesical seems to have increased the ability to do prognostic evaluation also in early disease. So we can start talking about cellular residual disease in the primary setting when we have detection of either of cells, cluster, or vesicle, compared to the molecular residual disease that we see in the primary setting. In any case, there have been questions at the beginning of our session regarding the use of cell-free DNA, particularly with regard to genomic alteration, monitoring the allele frequency. and also now tumor burden in primary settings. There is also an area that will not spend too much time, but is early detection of screening. That will be obviously the next evolution for liquid biopsy in breast cancer. Let's briefly review most latest data on CTC predictive value, particularly hormone receptor positive breast cancer. You remember the PACE study that was presented and is going to be published soon. And this is a post-CDK clinical trial, particularly the majority of patients were on Ibrance. And the patients were randomized 3 different arms: fulvestrant, palbociclib, fulvestrant, palbociclib, fulvestrant, avelumab. And the question obviously was, which is the best strategy in patients that have progressed after first-line AI and CDK4/6 inhibitor? And during this study, we actually planned and implemented a number of correlative studies. One of them, and extremely rare to see this in phase 2 randomized studies, in a CTC enumeration of baseline and staging in a progressive disease. So we know the clinical data that, in essence, there is no much difference between fulvestrant and fulvestrant palbociclib in terms of median progression-free survival. The only arm that appeared to do better is the fulvestrant, palbociclib, and avelumab. And this is in an unselected population, essentially without looking for any specific biomarker. Now, with regard to the CTC performed as we've done in other studies. So the CTC more than 5 was the group of patients. This is obviously almost 50% of the patients did worse. Again, this is post CDK4/6. When we asked the question of baseline CTC, can this identify any specific group of patients that may do better or worse? And you can see the difference in the CTC less than 5 that we call indolent disease. There is no major difference. But when you look actually at the CTC more than 5, so the most aggressive, the prognostically aggressive disease, this confirmed what has been seen in other studies, retrospective, prospective. The patient with single agent endocrine therapy fulvestrant have only a median progression-free survival of 1.9. So CTC evaluation during treatment after CDK4/6 suggests that this patient will now benefit from single agent. Of course, we don't have any data with regard to elacestrant, but we will plan to essentially bring this data together with the molecular analysis from the study, the other part of the correlative studies, and see how the CTC number will correlate with ESR mutation and the molecular analysis. So what about cell-free DNA? This is obviously the most important aspect of our management of patient NGS live to identify actionable mutations. First and foremost, which are the actionable mutations according to the NCCN guidelines? For breast cancer, we have PI3K activating mutation, for which we have the evidence from alpelisib, from the SOLAR-1 study. ESR mutation, where there's recently approved for elacestrant, but there are a number of other agents being developed, and I'm sure this list of FDA-approved agents for ESR mutation will increase. And I think it is very close to the approval of capivasertib for AKT, PI3K, PTEN, or probably for metastatic, primarily enriched in these mutations, as was presented with the Capitello 290 at last San Antonio conference and then published. So stay tuned for definitely an increase of this list. So this mutation needs to be detected, obviously, by NGS. When you look at the use of cell-free DNA in metastatic patients, our group contribute with this paper in eBiomedicine, looking at a landscape of DNA and mutation to different subtypes. You see that there is slight difference, of course, in the ER-positive patients. ESR mutations are enriched. Otherwise, p53 and PI3K mutation are the most common. And you see also a consistent number of patients that have LB2 mutation. I believe this is going to be one of the next mutation targets that is going to be in the guidelines. With regard to the triple negative, we've been talking about this in the prior case. Do we use NGS in triple negative breast cancer? Well, PI3K mutation are present in triple negative breast cancer, and it's possible that, again, the Capitello 291 will identify a benefit, a significant benefit in combination with Taxol, and that would have capivasertib also approved for this indication, increasing our possibility to treat these patients. Very early on, we identify also that the increased tumor burden with allele frequency is associated with number of sites, increased number of metastatic sites. So in essence, you can look at the cell-free DNA as a way to identify number of mutation that define a more aggressive disease, or tumor burden with an increase in a medial lead frequency, not only during treatment, but also baseline with a single measurement. Most recently, our group started to look at the interplay with different mutations, different variants, to see what this impact will have, not only with regard to the treatment, the response to treatment and targeted therapy, also to identify possibility correlation with the prediction of site of recurrence, and how we're going to model monitoring when we have this information. This is looking specifically ESR and PI3K, that are the most common ER-positive disease. You see here with the histogram the different frequency of distribution of these mutations. And you see also this is ESR and PI3K mutation specifically on the binding side of ESR mutation and the PI3K alpha mutations. So when you put it together, you see that some variants are more associated with CMV, for example, in the PI3K pathway. Most important, the two that we see relevant to the management of hormone receptor positive. There is a difference between ESR1-537. This is ER pathway, so making probably more sensitive to endocrine therapy, even in the resistant setting. And 538 with the cell cycle pathway, so more aggressive disease, suggesting that these mutations may be in the future treated with differential combinations. And see here, this slide is actually show the distribution of mutations and co-expression in relation to the metastatic site. So I think one day, probably with artificial intelligence, we'll be able to identify and predict the progression of this patient and also design really more individual treatments based on this information. Now, moving from the metastatic setting refractory to patients that have in fact already started treatment and may progress. You all remember the PADA-1 study was published by Dr. Bidar. And the interesting part of this study is they introduced the concept of molecular progression without having radiological progression. And how do we deal with this information once you have it? As we just mentioned in our discussion, we need to have the data to be able to use and to be able to implement. So the PADA-1 briefly was just looking at the ESR mutation detection while you were receiving first a baseline and then when you were on treatment to identify patients that may have developed a molecular resistance to an aromatase inhibitor. To make the long story short, when the treatment was changed based on that information without evidence or radiological mutation, you have a progression, you have a difference in the progression-free survival. And we also saw the progression-free survival too at the last ASCO meeting, suggesting that possibly this is a good strategy. Now they investigate in the SERENA-6 study, where camizestrant is being given in a randomized fashion with continuation treatment in patients that have been screened after 6 months of first-line therapy for detection of ESR mutation and without progression. So what about MRD that I think is the most important at this point development in liquid biopsy? We have seen what we do in the metastatic setting. Now we move into molecular recurrence. At this point, what about minimum of molecular detection of disease? So we talk about briefly about the circulating tumor cells in metastatic disease. These cells can also be detected primarily with the cell search system in the early disease. So in early breast cancer, more than one cells after completion of radiation therapy, local therapy has been associated with progression. And so this is the concept of cellular residual disease compared to molecular residual disease. Yeah, you probably remember this large study in Europe, primarily in Germany and Austria, a success study. They showed that the detection of more than one cell is associated to overall survival. This is the survival difference in this patient. They have demonstrated CTC before chemotherapy. So this is obviously not implemented in the clinic, but there was also another interesting study that was presented and published by Dr. Sparano, associated with an ECOG study. And this is primarily to detect CTC later between year 4, 5, and 7 to see if there was any correlation with late recurrence. So as you can see, there is an evidence that CTC that were detected in approximately 10 to 15% of the cases were associated with late progression, late recurrence. So clearly CTC can provide an information that is probably complementary, certainly different from what we have with molecular recurrence, and maybe the lead time is different. I want to introduce this case because it's a very good and interesting concept applied to patients when we have the possibility to really use this technology. This is a patient that came to me primarily for a second opinion. She had a diagnosis of an inflammatory breast cancer, skin thickening, accelerated adenopathy, the usual presentation. And this was also a triple negative. So she received treatment, a Memorial Sloan Kettering with the Keynote 522 regimen. She had a great response, almost complete response. And she had minimal residual disease in the lymph node. So we obviously discussed the fact that these patients have the best prognosis when they have almost a complete response. We calculate the RSA-B, and the patient went to receive radiation therapy. Because of this minimal residual disease, was advised to continue pembro and receive adjuvant capecitabine. She did everything she could to remain disease-free. So the only recommendation that I gave her, maybe we can follow minimal residual disease using a tumor-informed modality like the Signatel. So she had the first one that was not detected. Then in December 22, actually Christmas Day, she started to have one, this is arrived really the 24 in the afternoon, one molecule. We say, okay, we're going to repeat in 3 months. And 3 months later, without any symptoms, she had this jump. You see March 21st. And this was already an indication. She was panicking, of course. The first thing that you do when you see this report is you do a PET scan. So she did a PET scan and she had adenopathy. Again, non-symptomatic. It was biopsy, was a confirmed recurrence. She went back to Memorial, randomized a single agent therapy with Rubin and Tropion-3 study. She has been doing well, as you see from the prior, and there was some decrease in the number of molecules. So now we are monitoring tumor burden. Of course, she had also PET-CT staging according to the clinical trial. So what we are trying to do essentially with MRD, with molecular detection, is to identify minimal amount of disease well ahead of the clinical recurrence and possibly change the outcome of these patients. So this was done in prior clinical trial. This was presented by Dr. Mangumba. This was the I-SPY trial. The patient that had completed neoadjuvant treatment were actually undergoing MRD detection using the Signatel test. It's a tumor-informed 16-gene signature. And there was evaluated at different time points, but primarily after patient had completed treatment. And these the patients had also mama print, and the mama print high risk, but also evaluated. So you see that in terms of detection, the subtype that has a high, of course, detection is a triple negative and the F2 positive, and also the mama print high risk. So clearly, the more aggressive disease, they have less response to neoadjuvant therapy, can be really identified as a high risk and possibly monitored and possibly associated with monitoring the adjuvant setting when you have a larger disease, a triple negative disease, and also mama print high risk. In reality, what we do in the majority of ER positive, this remains still a question that we need to address. So when you look at the outcome of these patients, you see that this combination of pathological CR together with the detection of MRD after completion of primary treatment was also associated with outcome. So this is an important aspect, but the question is how much time we have before we can actually intervene and treat this minimal residual disease and pushing really the clinical detection of the disease. And you can see this from an early study from Dr. Coombs, that the median lead time, primarily again in patients that have HER2 positive and triple negative disease, is 8.9 months. So we have some time for intervening, and we need to design these studies, and these studies actually are ongoing, where we can intervene and try to clear the MRD and possibly delay the progression of this disease. This is the list of the clinical study on MRD detection in early breast cancer that have been published. And you can see the different lead time in different studies. Some of them were reported 11 months, 7.9 months, 18.9 months. So having a longer lead time for several reasons. First of all, because maybe you're reaching a ER-positive patient that usually delay recurrence, gives us more time for an intervention. So this is a potential scenario for MRD detection in management. So we can simply measure the MRD clearance in patients that have adjuvant therapy after neoadjuvant, right? And this is probably the use that many people will do right now if they are not available clinical trial. And then with the MRD increase, you can associate it with outcome progression. This is mostly tumor-informed targeted approach. The studies may be looking also at stratification based on biomarker and maybe using new drugs or standard of care to see how this MRD may be eliminated and controlled. And this can be done in multiple ways for selection or for simple stratification. And of course, as I say, in a neoadjuvant setting, this could be an indication that you can escalate strategy or having a second line adjuvant therapy when the MRD is still present and detected. But not always is possible to run a tumor-informed test, particularly if you are looking at the setting of a late recurrence or patient that may have a need for a switch therapy. So in that case, there is a combination of methylation and copy number alterations. And this genomic alteration and methylation are putting together one of these tests available now is Guardian Reveal test, for which there is not much data in breast cancer, but there is data in colorectal cancer. As we mentioned before, in colorectal cancer, most of the tests available for MRD have been found to be extremely effective in predicting patients that may have a recurrence. We have a recurrence for which eventually you can intervene with different adjuvant therapies or even a second adjuvant therapy. So we obviously looking for generating the data for the Guardian Reveal similar in breast cancer. In our group and our collaborators are working very closely with Guardian to actually design the studies, really implement at some point the information. Again, the advantage being that is not tumor informed and possibly with a lead time to give it more time, especially in the ER positive where the tumor informed seems to be less effective. So this is a list of the available, commercial available assay, particularly in the US, tumor agnostic and tumor informed Signatera Guardian Reveal are probably at this point the most common. And this is a number of phase 2 studies where we have incorporated the cfDNA, some of them based randomization on cfDNA, elacestrant and endocrine therapy, important for the discussion for DR positive, capecitabine, talazoparib, and of course pembrolizumab. So what about a liquid biopsy for screening? Obviously, this liquid biopsy use is moving in a early setting, and the holy grail would be having a blood test that we can use on large scale instead of sending women to mammogram, and with mammogram not be available, to screening not be pleasant because of pain. So can we do a blood test eventually will resolve all this problem? So this will be an interesting area because once you have a screening, you can have a tumor agnostic screening test that can direct you to the different modality. Of course, for breast cancer, mammography will be still standard of care because you need to have a biopsy. In that case, essentially everybody will be a stage 1 instead of being late diagnosis, stage 2, stage 3. And if you were to have a very sensitive test, maybe a combination of detection of cancer cells, immune cells, that can even get in the preneoplastic phase, then you can probably have an intervention represented by a prevention strategy because we are not able to see anything in this setting. Can we see DCIS? Can we see LCS? Can we see atypia as a response, immune response to these changes in the breast? So as we know, there's been already a number of attempts and tests have been generated. This is essentially the multi-cancer early detection test called as Galleri or GRAIL, has been developed looking at CCGA discovery and development. Say with a combination of methylation and protein expression, and this validation is performed. But now when you look at the validation published, you see that breast cancer is not among the disease that can be detected very early on, particularly stage 1 ER positive. But there are obviously the GI malignancy, again, they are the most easy to detect in this setting. In any case, there is the Pathfinder tool that use this design where women are also invited to participate 20,000 participants age 50 or plus. You may have had a disease in more than 3 years ago. So our survivors are motivated to participate because they may detect after a new primary. So this is a multi-cancer detection. You have essentially a blood test that can be a single detected or not. If you have a single detected, you go to your recommendation for additional detection, and there is no cancer identified, then you have a PET-CT, research blood, and continue follow-up. So every patient will be directed according to guidelines for their specific tumor possibly indicated by the test. You see, if it's identified, of course, there will be an early detection of disease that will be managed and routine screening. So it's an ambitious project because we rely on standard imaging to detect something that is at the molecular level, but in a population that is relatively high risk, certainly molecular test in these patients, we'll see if it's informative or not. Finally, this is a summary of what essentially a cell-free DNA and CTC can do in this setting. We can really identify in the future early detection. For now, we can monitor progression. We can monitor resistant mutant clones, particularly ESR, PI3K, AKT, and HER2. We can look at molecular recurrence. With regard to the MRD, we have tumor informed that are probably more important for HER2 and triple-negative breast cancer, and non-tumor informed.
I think there has been some interruption.
Can you see me still?
Yes, yes, yes.
Sorry, there was a, yeah. So summary of conclusions, CTC, cfDNA detection, and molecular analysis are increased use in clinical management. Of course, depends on access and the costs and all of that. But in metastatic disease, we can really look at the recurrence very early on, the molecular recurrence, the longitudinal studies. As we discussed previously, it's important to assess the heterogeneity. So it's important to understand what your baseline molecular test will look like and your baseline tumor burden. That's why I use liquid biopsy very early on, because I want to see the evolution over time. During first line of therapy, obviously, it is very important. High risk of molecular disease and cellular residual disease is what is developing right now. During neoadjuvant therapy, as a tumor burden evaluation when immunotherapy has been used in the context of I-SPY, and I think it will become eventually available also for clinical use. And the future application, of course, is initial diagnosis of precancer. So these are many of the collaborators. We have this consortium of precision medicine with MGH, Washington University, University of Udine, and the different members in Northwestern. Of course, we have also other disease sites. Dr. Kazi is extremely involved with our group, with our collaboration liquid biopsy. This is my lab, still working on a number of molecular analysis, CTC, single cell analysis, and so forth. And these are collaborators with different companies. We have technology in our laboratory. We, of course, we collaborate also with regard to clinical studies in our funding agencies. And thank you very much. I want to remind you, just a liquid biopsy conference next month. It can be virtual unless you want to travel to Madrid, but you're going to Madrid already for us.
Already. It's a bit for this time.
Yeah. Thank you.
Thank you, Dr. Christopher Nilly. Interesting session. There is a question from Dr. Rami. He's asking, when MRD is positive, shouldn't we treat? If yes, why and how? And if we shouldn't treat, why?
So if MRD is positive, you first want to make sure that there is no evidence of detectable recurrence. And if you have no evidence of recurrence, depends on which setting are you operating. Meaning, if you are in ER positive, a single agent adjuvant therapy, you may want to consider adding a CDK4/6. Depends on, or you may simply monitor on a much closer interval. Instead of doing an MRD testing 3 months later, maybe 1 month later. The case that I presented was a very aggressive type of disease. But if you were to have an ER positive disease, probably you have 6 months or more to detect this recurrence. So you want to always try to see the trend. You know, in my opinion, any test has to be confirmed. It has to be demonstrating a specific trend. I didn't have time to present another case where we had evidence of much slower increase in the number of molecule by the Signatera test. And this woman had essentially persistent finding on a local lymph node at the point that because she did not want a systemic therapy, and over time, she has always the same findings, she proceeded with local regional treatment. Those lymph nodes were in fact resected. Now we are waiting for the post-surgery to see if this is the only treatment for the local disease for which there is no high tumor burden. Can we actually intervene in that particular way? So you can imagine MRD application different way. One of them is when you do single local treatment, for example, for an individual SRS for a liver lesion, if there is no much of progression over time.
I know we are running behind schedule, but just one question from my end, because it's a very interesting topic for me. In MRD setting, when it comes to biomarker, what is your opinion on ctDNA versus CTC, and in ctDNA, tumor agnostic versus tumor informed approach, or a combination maybe?
Yeah, this is obviously a very important question. I think once you detect MRD, let's say Signatera obviously doesn't give you any molecular information. I want to know if there is any evidence of resistant mutations. If I want to modify or a targeted therapy, I may use obviously a Garden test or any other informed. Well, ideally, you know, I like the CTC very much. So we know, for example, if you were to detect CTC, you have an ER positive or HER2 positive CTCs, and that's a setting where you can intervene, you can act. Interesting enough, we have HER2 expression in CTC in HER2 low tissue, suggesting that maybe these are the patients get more benefit from an HER2 compared to setting where you don't have that. And I had a patient where if we had to decide between two, there is a 2+ in the tissue, there is no CTC, but there are CTC. You can decide to use Trodelvy instead because it's an ADC that works better probably in triple negative patients. So I think the more you redefine your subset, which depends on the biomarker that you want. You want to look at expression of this biomarker for your treatment, CTC are ideal. You want to look at specific mutations, having a molecular test on top of the MRD, I think is very relevant as well.
Great. Any questions from other faculties to Dr. Massimo?
So I think we are running short of time.
Yes.
I will. So I just wanted to thank both Dr. Jamie Abraham and Dr. Massimo Cristofanilli. This has been a huge advantage to all of us to hear all this data so simplified and brought to us in one capsule. And Massimo, my head is exploding with all the liquid biopsy applications and wonderful data. I think we are itching to utilize more of liquid biopsies. And what I learned from your presentation is there are varied applications of even the quantification. We are not utilizing that much of the quantification of liquid biopsy, which is, you know, longitudinal tracking, even the MRD monitoring, and more so we are utilizing liquid biopsies in quality. So we are looking for the specific DNA mutation, and a lot of this is being utilized as a complement testing to tissue-based testing, more so in lung, and less of the quantity tracking is happening at the hands of most of the clinicians here, but quite an eye-opening session to understand the different applications. And I think both in metastatic disease to track the response, as well as the early disease to capture the MRD. I think the biggest application will happen once you all have figured out, if you found the patient to be MRD positive, what exactly should be done for that patient. And once the guidelines include that, we will have to put these in our clinical practice. So again, personally, from my side, a big thank you to both of you. I think Dr. Abraham was still logged in. I think he would be logging out right after Dr. Christopher's session. But back to you, Darshana. I'm speechless. I don't have too many questions. Actually, I have so many questions that I won't open my mouth. So back to you too.
Thank you. And now with this interesting session from Dr. Christopherlini, I invite Dr. Ved to discuss the cases. I know we are behind schedule, and I really thank Dr. Ved for his patience. Shall I share the screen for the cases right now?
Please, Darshana.
Yeah.
Please go
Yeah.
ahead. I think by the time these slides come up, let me thank Darshana and Sevanti for setting up such a wonderful meeting, and thanks to all the faculty for the wonderful presentations. A great learning experience it has been. And let's go ahead with two case presentations. These cases have been brought up from Sevanti's clinic, and these are real world cases who have been treated by her. And let's see, go through, these are two different case scenarios, and we would try and dissect some of the pertinent issues about it. I'll go through the case presentation quickly and then come to the discussion with the faculty. This is a 33-year-old lady diagnosed with a left breast cancer, node positive in 2018. She had a grade 3 ERPR positive, HER2 negative, and a germline panel was negative. So she received NACT with adriacyclo, followed 3 weekly, and followed by a breast conserving surgery, and which finished in 2018. There was a 1.5 by 1 by 1 centimeter disease, which was still viable, and received post-operative, completed her chemo, radiation, and was put on maintenance tamoxifen, leuprolide till July 21. Now, this lady wished to plan a family, so she stopped tamoxifen. Now has a 10-month-old baby and had just started having her periods. She presented with low backache, and MRI spine was multiple areas of metastasis. There was on the PET scan, a left breast lesion. There were lymph nodes in the axilla, subpectoral region, and multiple skeletal metastasis as already enumerated. And tiny nodules in the lungs, a typical diffusely metastatic disease, multi-system, and a repeat biopsy was, this was suggestive of a hormone receptor positive, HER2 negative, and nothing in the past or the family history. Next slide, Darshana. So that's just to show you the scan. Next, and she was put on tamoxifen since she had actually stopped tamoxifen. She hadn't become resistant to it, and with Zoladex and ribociclib, denosumab, and calcium supplementation. Next. Biomarker results. We did have some discussion about that. Sevanti, you had put forth the options and the points. And this lady was TMB low, MSI stable, PDL1 negative, and PIK3CA. This was PE545A. And ESR, this was also P536H. And the allele frequency you can see coded out there, and FGFR 1 amplification 11 copies. So a lot of things happening here. So let's go to the discussion part of it, and then we'll dissect out all those abnormalities one by one. Now, Siddharth, let me begin with you. How safe it is for a hormone receptor positive young lady to plan a family, and why would the recurrence have happened? We were alluding to it earlier as well.
So I completely, that's the first thing that was going through my mind, was that why wasn't she counseled prior to treatment about, harvesting the ova and preservation and the potential of IVF or a surrogacy, etc. Because we know that from a few European papers that 3 years post treatment in a triple negative or a HER2 negative cancer, which is ERPR negative, positive cancer, which is ERPR negative, you can plan a family. But at 33, if you've got a strongly hormone positive tumor, to restart or try and give your body a hyperstimulation of estrogen and progesterone, which are the founders of your cancer, was possibly a mistake, in my opinion. I think this should have been done, and we've treated so many cases together like this, where we've actually counseled the patient pre-therapy into what it takes to, she might not be able to be fertile, but I just think somebody missed a trick there. That's what I would have done today.
So let me go around the panel. How common is the, obviously at 33 years, you have brought out a very pertinent question. And Dr. Darshana, Dr. Menon and Dr. Srinivas, are they still logged in?
No, both had to log out due to some prior commitments.
Okay.
We have Dr. Krug and Dr. Limay.
Yes. Okay, Tim, let me get across to you about the comment already offered and have your viewpoint on this.
Yeah, I agree. It's clearly a risky thing to do if you've got someone who's got a estrogen-driven high-risk cancer. I know the positive study said that if you stop endocrine, that the risk of relapse is the same between patients who stopped and patients who didn't. But a case like this clearly implies that this must be a risky thing to do.
So thank you so much for that observation. Now, Sivanti, I'm sure a lot of discussion would have happened in the clinic, and we do get across with the discussion with our patients, and a lot of things happen actually. The access and the inclination at the time of diagnosis, and then of course a change of opinion and change of attitudes post the treatment. So, Sivanti, your comment.
So this patient actually came to me with the metastasis, as happens to be the case in at a lot of times, because I run the quote unquote precision clinic. So mostly ends up, a lot of my cases are advanced stage disease. The harsh truth that I realized once I relocated to India is a lot of the young patients are getting treated without a proper counseling for ovarian preservation, fertility preservation, not ovarian preservation, but fertility preservation, and or for oocyte preservation for appropriate family planning. So as much as we are really pushing the case to make our patients relapse lesser, live longer, we are truly struggling to give them quality of life if they were to survive this disease. And so this patient, of course, was emotionally challenged and underwent this whole experience. And whether as a result or you have presented the genomic analysis, and whether as a result of the genomic signature or as a result of stopping the hormone therapy, lo and behold, we have this patient today with advanced disease.
Yeah, very unfortunate situation. Thanks.
Can I just ask a question here? Sorry to interrupt. Can I just ask a question? We have this genomic analysis now post-pregnancy, right? Once she's had, we all know that the estrogen and progesterone level reaches a supranormal level to maintain and carry on the pregnancy. How much of that could be a contributory factor towards causing these changes in the genomics? Because we have nothing pre-metastases, but we do have it post-metastases. So I mean, how much would that influence the genomics as well?
Thank you, Siddharth. And I have the next question actually to Massimo. That partly, Siddharth, what Siddharth raised as an observation, and the second question, that we have seen the profile. What should we be doing now? Massimo, if you
Yeah,
could.
so if you do back to the profiling, I think in answering somewhat one of the questions that was raised, certainly ESR1 is an acquired mutation. This patient did not have a ESR in the primary tumor. If you were to go back and profile the primary tumor, you would not see that. PI3K is a founder mutation, so clearly it would be there as well. It will not change the management or the monitor of this patient. So right now, I think the difference from the primary tumor is that she acquired an ESR mutation while she was on endocrine therapy that's probably responsible for some of the feature that we see. I mean, this actually makes me think about the paper that we just published and we presented, of course, I presented data. So what are we going to do different based on the profile in terms of treatment? And I think we're going to go into the treatment in a minute. The other thing is that, obviously this woman deserves a liquid biopsy, right? I mean, she seems to have a significant tumor burden based on the number of sites that are involved. Minimal lung, at least small lesions, but certainly significant active disease in the bone. So certainly this will be one way to monitor whatever therapy we'll discuss later. And just to go back to the prior assessment with when to stop and when not to stop, wouldn't be great if we were to plan in the future to do an MRD testing every time a woman wants to decide to stop. Let's say that an ER-positive disease with a test as MRD positive may have a lag time between 8 to 15 months or so. But if you were to have an MRD testing negative, we would feel overall more comfortable. So this is a setting where we should probably investigate. I know the clinical trial provides some indication that it's safe to do it, but then you have these individual cases, and I have a similar cases, heartbreaking really, that she did what she wanted to do, even if she went to family planning. And then eventually she ended with bone metastasis, and then eventually she ended with liver metastasis, was triple negative. I mean, this disease keeps evolving, particularly in young women, and sometimes there is nothing that you will do. It will go that direction no matter what.
Thank you so much, and the wonderful point that liquid biopsy. So we are learning more that another application of liquid biopsy which could come in and would be a useful tool in the practice. Tim, your comments about the two mutation pathways we have actually enumerated here, PIK3CA and the mTOR.
I think that mTOR activation as a result of PIK3CA is striking. So alpelisib or everolimus, if one is an everolimus fan, would be quite reasonable in my view. I like FGFR1 amplification too, although the drugs are not yet freely available. We did the study here and found some very active FGFR1 antagonists. There's multiple therapeutic opportunities here, aren't there?
So what would be the last question which is listed out here? I'm jumping to the last question since you are on therapy at the moment. What would be your take on the most effective therapy for this? One final advice.
What was her last? Was she on? This is a patient who's stopped adjuvant endocrine therapy.
True.
Yeah, and she's ovarian suppression.
No, she didn't receive ovarian suppression.
No, that's what I would do. I would Zoladex or Goserelin, letrozole, CDK4, ribociclib.
So
first line anyway.
So Massimo, your comment on the FGFR and your choice of therapy.
Well, let me say that obviously, CDK4/6 inhibitor is definitely recommended. We can have an argument, but we don't have time for which one and what will be the first line. I think ribociclib is certainly reasonable, especially with a premenopausal woman. I would not give an AI because she has an ESR mutation, probably will go phosphodiesterase in that case. FGFR amplification may be associated with resistance to CDK4/6, but you don't have indication that is upfront resistance. And in fact, even PI3K mutation is not limiting the efficacy of the CDK4/6. So for me, FGFR amplification is an interesting, data that we need to see and monitor. There are no agents, though. The first more actionable is the choice of endocrine agent based on ESR mutation, and otherwise a CDK4/6 inhibitor. And I will keep the PI3K mTOR pathway for later.
So if the ESR was positive out here, then what would have happened?
If it was positive in the primary tumor?
Yeah, if that would that have changed your approach? The choice partner.
This was 1 to 3% of the cases. So I think the only agent that we have available that may work in some of these variants, again, we don't have time to go over the variants, is the fulvestrant. I'm sure elacestrant is not available to you, and you will probably not start elacestrant as a first line in endocrine resistant without having been exposed to CDK4/6. The data are clearly post CDK4/6. It will be actually a good way to monitor this patient because the patient responds to CDK4/6 stays for a long time, and we have a persistent variant of ESR mutation in cell-free DNA. Then that's probably the setting where elacestrant can become useful. We don't know if it's better to target PI3K at that point or ESR, but that would depend on the variant in the cell-free DNA. Which one is the predominant driver mutation at that point?
Very well. Thank you so much. And Sevanti, your thoughts on the causes of endocrine resistance.
So, here I'm quite nervous for this patient because yes, the fulvestrant needs to come in, the GnRH analog needs to come in, and the CDK4/6 inhibitor needs to come in. But we do know that these two pathways will pose challenges for this patient, for the CDK4/6, the PIK3CA, and for the hormone, the FGFR amplification. We don't have drugs as of now. So just as a fast forward, today I saw this patient in clinic, and she has the 3-month scan available, and she has had significant response. But the problem still remains where I didn't have answers for these two pathways, and a submission to the entire group here that the testing was done, but I didn't have immediate solution. And it is great that we are discussing this case, and I'll have something to go and convey to the patient. But the challenges are such, we need to get into understanding, because this data is going to come out. There's going to come out more and more. And that will be a challenge for us, where we'll have enough of this data, but we don't have styles of application. So all I told her was that we need to watch out. We need to have a close surveillance. And now after this discussion, we will also talk about liquid biopsy.
Thank you so much. And I think in the interest of time, we are already 7:56, and then we have close to about 5 minutes more. And Darshana, could we move quickly to the second presentation, because there is a very interesting case scenario out here. And this is a 59-year-old woman who had left breast cancer with oligometastatic disease in the L5 vertebra. And this was ER 5/8, PR 5/8, HER negative, and germline positive for BRCA2. Now that's the situation here. She received post ACT. I would trust this was a dose dense. She had a bilateral mastectomy with lymph node dissection and residual viable invasive breast carcinoma of no special type, still with lymph nodes, a lot of lymph nodes positive. And she has had hypertension and surgery, which is the hysterectomy and oophorectomy in the past, and her sister had a breast cancer, and that probably was the reason that at 59 she was tested for germline. Now, can we have the next slide, please? Now, Siddharth, let me begin with you again about the high-risk disease. So, how do you put this patient, and in your practice in general, where do you put the high-risk disease?
This is high-risk disease, and your second question is what I was asking myself: why was there no platinum added to the paclitaxel in the first place? Because she just took paclitaxel, and then of course there is. I mean, you would add olaparib, as we've heard from these things, and I think the problem with the BRCA testing is you have to explain the pattern of testing to them, and everybody in the family should get tested. It's not just the person with the disease.
Oh, Tim, your response to the role of platinum, question mark? Tim, can you hear me?
Yeah, hello. Yeah, I must admit I'm quite a fan of using platinum at the right time in BRCA 1-2 or PALB2 carriers with loss of function variants. I've had some really difficult situations clinically that have responded particularly well, including intracranial disease. So there's a time and a place for it. I wouldn't necessarily use it straight away, but I'd certainly keep it as an excellent salvage option, shall we say?
Musima, your comment on that?
Yeah, I will not have used platinum for an ER positive for neoadjuvant. And we know also that when you use a neoadjuvant may decrease the efficacy of the adjuvant or olaparib, that for me it would be the ideal for these patients in terms of choice among the three, of course, endocrine therapy as well. And we know that the PARP inhibitor are the best targeted therapy in this setting, and the CDK4/6 don't seem to work very well in the metastatic disease. So why exposed to 2 years of abemaciclib, someone that would probably not benefit from? Yeah, that's my summary.
Yeah. I'd like to add to Massimo that I wouldn't use platinum in the neoadjuvant or adjuvant setting in this patient, but it might have a role somewhere down the road in the metastatic setting.
Absolutely.
Very
Absolutely.
good.
Would be number one drug. Yeah.
In the light of the Monarch E and the Olympiad, both, what would be the best maintenance for this lady? ER positive, PR positive, and BRCA2 positive. Massimo?
Yeah, no, I think I mentioned that olaparib would be my choice.
And
because we don't have any information about the BRCA status of the patient in monarchy. But if we extrapolate, sometimes, medical oncologists like to do that, jumping from one side to another, from one evidence or real world evidence to another, is more likely than not that we're not patients or not enough to make a conclusion how to measure the efficacy of abemaciclib in BRCA mutated patient. But the olaparib, I think, is the strongest level 1 evidence that we have.
thank you so much. And Tim, what would be the partner with Ola for you? Tim, could you hear me? So anyway, Sevanti, what would be your take on this? Ola, and then what would be the partner drug for you?
So I have the patient on letrozole and olaparib. This patient, so it was a very big learning. The patient, just going back, was actually given platinum and taxane as a weekly dosing, and then realized more data around it, that this was a hormone positive patient where the BRCA positive, and there is actually limitation of data, but there is data that platinum may not be as beneficial. right around the time the first dose of platinum plus taxane was given, her diverticulitis really acted up and she was admitted with query perforation. And I realized that even a weekly carbopacly was tough on her because of her clinical condition. And so I completed the therapy with weekly pacly, only to find out that she had still a lot of residual disease. So to come back to your question, I would give olaparib plus letrozole.
So if I may summarize, Tim, are you there for a final comment? So I think we lost the connection. So role of platinum would be a question mark, still remains a question mark, and Ola plus the aromatase inhibitor would be the right way to go. So we are off CDK4 inhibitor in this clinical scenario. You agree with that?
Yeah.
Correct.
Yes.
Yeah, wonderful. I think that's great. And I think we are past the hour now. And I take this opportunity to thank everyone. Massimo, Tim, Jamie, Siddharth, Sevanti for setting this up, Darshana for such a wonderful meeting, and all those who participated. Back to you, Darshana. Thank you so much once again.
Thank you, all the faculties, Dr. Massimo, Dr. Ved, Dr. Limay, Dr. Sahani, as well as Dr. Jamie and Dr. Menon, as well, and Dr. Srinivas, who had to leave early. And a special thank you to all attendees for being patient and attending the session with us. And we have certain questions still left unanswered. We'll make sure to get back to you with those answers through your email IDs. Thank you, everybody. Good night, good evening.
Thank you. Great learning for me.
Thank you.
Same here.
Same here.
Thank you, everyone.
Thank you.
Thank you.
Okay.